Happy to be here. How about you? Okay. So I'd like to introduce Dr. Jeff Carter. Dr. Carter is the Chief of Burn Program at the University Medical Center, professor at LSU Health Science Center, and also the president-elect of the American Burn Association. I've known Dr. Carter for about 15 years. We worked together several years ago at UMC Chapel Hill, and anyway, it's one of those things where I hope you never have a burn injury, but if you do, he's the person you need to see. So anyway, a lot of other things I could say, but without going into a lot of details, he's just an incredible instructor, professor, surgeon, and guy. So without anything further, Dr. Carter.
Thank you. With me also is Mr. Ed Robert. So he is the CEO of Polynovo. It's a large company that we work with in healthcare, specifically in burns. And when I had an opportunity to do this, and Ed was going to be in town, I was like, you ought to come, because I'm talking about partnership with doctors and what a pain in the butt we are. And he works with a lot of them. But hopefully you will too. And so I bring this up because there's a lot of things when we talk about health economics that I've learned from Dr. Kearns and others, and I just have to start with my disclosures. Whenever you have, especially a physician in front of you, they need to tell you what their disclosures are. So I'm a stockholder in Spectral. I'm not going to talk about that. I'm a consultant for those companies, but I donated it all to charity. Serve on a couple panels and boards, and I have a lot of research dollars. And that's because if you want to make things better for the next generation, you've got to study and figure it out. This is not my money. Most of this is money goes to schools. But it's money that enables us to be able to figure out a better way to treat the next group of patients. This is an important way to start class. Okay, so you get me like one night a year, and you might get Ed one night ever. But I was giving a lecture earlier today, and I put the same pyramid up. It's called the learning pyramid. So if I just lecture and talk, you have about a 5% retention. You ever wondered why when you read the book chapter, but you got to see on the test? It's because reading is a 10% retention. Reading alone is a 10% retention. Audiovisual, like a PowerPoint, about 20%. Demonstration, 30. Discussions, 50. So sometimes it can feel like, I don't want to interrupt them, but I want to ask a question. When you're discussing things by asking questions, you have active learning. And that means you'll remember more of that. And maybe that'll be something that's important to you. Maybe you'll change your behavior or your values from that. So classroom shouldn't be one-way information. It should be back and forth. Same thing if anyone's online and you have questions. So I bring this up because it's an important way to think about it whenever you want to make change. And by the way, that retention's at 24 hours. Not 7 days, not a year, 24 hours. But think about it in the organizations you work with. If they're having you just do PowerPoints online, how well is that going to actually make the change? So as I move through, I want to very briefly talk about economic literacy in doctors. It's not something for us to brag about. What does partnership mean with physicians? And then, what is coding? Because you might not think it's very important, but coding changes everything in healthcare. And then what is a BAC or a GPO, just briefly at the end, because those are things that you will work with on a regular basis that are very important. Right now in healthcare, we are a volume-driven event. So if I take you to the operating room and I do a surgery, I get paid X amount, hospital gets paid X amount. If I take you to the operating room, I do the same surgery, just slightly different, I get paid that, hospital gets paid that. Even if it was a complication you had because of my first surgery. If I keep doing procedures, I get paid every single time. And that's not necessarily good. What you want is a value-driven system where people who do really good work get paid better. And if you're not doing as good of a work, we help coach them to get improved. And they think that by doing this, we can lower the total cost of healthcare. Likely it's going to be about the same. We're not going to see, in my opinion, too much of a change. And that's because of the aging population, and I'll talk about that in a second. If you don't leave with anything else, I would say this is the formula to leave with, okay? We were talking about this earlier. Everyone wants high value care. So one thing that everybody can agree on. If you talk to patients, payers, providers, facilities, they all want to have high value care. So if Ed comes to me and he has a product that's going to increase my cost, but it's not going to change the quality of the care or the type of care I do, then it decreases my value. That's not good for my patients. If he says, this product costs more, but I can cut your hospitalization in half, that'll cut your overall cost down, cuts my cost down, and if it improves my quality, well, that's great. And so it improves my value. If you're a parent and you have a child that's injured, you have a loved one that's hurt, has cancer, whatever it happens, you want to find a good place to take care of them in service. How well they provide that care, that's quality. Does this all begin to kind of make sense? So opening a burn center meant providing a service to the community that didn't previously exist. So it was a big plus. But then we wanted to do it really well. That was verification. And then we want to do it at a low cost. So I'll show you at the end how all that comes together. So, you know, I mentioned that it's the one thing that combines everybody, and patients demand it. Nobody wants to go to low value care. You know, Louisiana was one of the few states that has charity care, had 13 charity hospitals down to one. And that's sad, but that's the truth, is that some states, like the previous facility I was at, if you go to burn and you didn't have insurance and you were outpatient, not inpatient, you had to go to a payment plan, have your payment plan agreed before I could schedule you for surgery. That's terrible. You're talking about something that hurts, talking about something that, you know, if you're concerned about how it's going to scar and look and other people see it. But patients want high value care. And so I really think we have a lot, and all the negative that we hear about Louisiana, we have a lot to be proud of. We have a 288-year legacy of providing care for those who need it. So, like I said, it unites all of us. And then value can be dynamic. If you just do cost can change. Think about what happened with COVID. Cost can change, and it's not really what you want to measure. What you want to measure is value. You know how much a ventilator was worth during COVID? You can sell ventilators for a lot of money. You know, there's a doctor I know that was selling box of masks that you and I can go buy for $5 at Costco for $50 online. Still has them listed online now. But I mean, I'm not saying it's a good thing for doctors to do that, but it just shows you how things change. Now, one of the other things is like, why have a doctor come talk to a group of people who are in, you know, business classes and stuff, and leadership classes? Because I happen to love business. I happen to love how it impacts patient care. And you know, I've had the pleasure of writing a lot of papers with Dr. Kearns, and some of the papers I've had a chance to write about really look at like how it impacts care. So when Ed has a product that's going to change something, I want to know whether or not it changes my cost. I want to know if I have someone who wants to go to NP school, is that a good decision for that person? If I have someone who wants to go become a burn surgeon, is that a good decision? And so I gave that talk to the students in the surgical interest group, and I think they all left impressed. We're going to talk for a second and about why healthcare. Okay, so this was from my grandfather's office when it closed. He was a general surgeon in a small town in Mississippi for a long time. And when his shop closed, I was going through throwing things away. And these are some x-rays from the 1950s. If you look, this person, there's a big white thing over their neck right here. It used to be walking a lot of spine, so he knows these x-rays. He knows that's not right. If you look at their lungs, it looks like there's like snow. Lungs should be black air, not snow. You should only see ribs. This is a year later, and if you look, it's even worse. It's like there's even more white stuff everywhere. That's metastatic cancer. It's a neck mass of metastatic cancer. And then if you go one more year forward, it's like, whoa, that neck mass is gone. I can see the bones in the neck. What changed? What happened was radioactive iodine came out between here and here. One pill, one drug, completely changed this form of healthcare. So the only thing that we know in healthcare is that care, coding, and compensation will change. That is the truth. It will change dramatically. This is Charity Hospital, not too long ago. If you look closely, there's 2 heads per bed. This picture was up at an auction and it's all pictures of old charity hospital, and everything was pictures of the building except this one is just pictures of the patients. I told my wife, like, this is what I'd like for my birthday. It's really important to me. She said, why? I said, because I can reproduce all those other pictures. This one I never can. And it tells you about the people who were here and the people who care for them. You know, that is a remarkable facility that cared for over 3,000 patients with only 1,800 beds. And what's interesting is that if you go back in time, rich people used to just have the doctor come to their house. And people who couldn't afford a doctor to come to the house would have to go to the hospital. And then hospitals started getting things like x-ray machines and operating rooms, and you couldn't have that in your house. So then you had to start going to the hospital, and that's when care really began to change. In fact, that's the charity hospital in the heyday. It's all clean right there. It looks a little different than today. You know, but technology made us begin to build hospitals and build them differently. And then something happened where I think we just kind of went off the rails. Hospitals have really gone through a lot, so is healthcare. In fact, if you look in the United States right now, it's a little concerning because we spend almost 20% of all the revenue in the United States on healthcare. You think about that, that's $1 out of every $5 is going to healthcare, and it's not going to schools, it's not going to defense, it's not going to infrastructure, it's going to healthcare. That's a lot of money. If you look at how we compare to other countries and how we perform, here's the United States per person. We spend a lot more money. In fact, we spend over $12,000 a year per person in the U.S. And if you look at how we perform, you know, the red dot is the United States, and we're not doing too good. If you look, we're far on the left, with the exception of heart attack mortality. We do pretty well in that. But we do very poorly in a lot of different measures. And that's not okay. If you look at the service we provide and said, you know, if we just had enough nurses and doctors, this would all be okay. You're going to like this if you're a trip to India. I don't know if you've seen the statistics. I looked at it, I was like, how many nurses do we have in the world? And how many do we have in the United States? So a good friend of Dr. Kearns and I is the former president of the American Nurse Association, Ernie Grant. So I talked to Ernie, and he's like, you know, this is where you can find the data on it. So we have a big nursing shortage, that's known. And the U.S. has about 4.2% of all the world's nurses. Excuse me. What we're looking at is, where am I drawing a blank here? We have about 4.2% of the world population, excuse me, but we have 15% of all the nurses in the world. 4% of the world's population to 15% of all the nurses. If you look at it from doctors, we have 4% of the world's population, but we have 25% of all the doctors in the world. So in other words, our resources far exceed others in comparison. We have a lot more nurses and doctors than what we probably should have. It's interesting too, because if you look, there's a physician shortage, and the nursing shortage was going to hit the healthcare system before the doctor shortage was. And then COVID happened, and it made it happen faster. Increased demand, didn't change output, and then we had some that were tired out and got out of nursing because of COVID. So nursing salaries have increased. Now you're about to go through a physician crunch. So the only shortage that we know of is going to be in colorectal surgery, and it's not going to. The only shortage that we think there's not going to be is colorectal surgery in the Northeast. And this is unfortunate because about 35% of patients right now struggle finding a doctor, and that's going to get worse. When we look at quality, this is one of the things I used to do a lot of research with education. 5 to 34%, depending on who you read and how you classify it, patients suffer an event that we caused. 5 to 34% of patients suffer an event like that. If you thought about it, if 1 out of 20 tires come off the car that Costco went and put new tires on, then Costco would be out of business. It takes 17 years, I quoted this earlier, to go from bedside and to get to the bedside from the bench. In other words, if we come up with a good idea and tell me I got an idea for a drug or for a device, and I got to work on it, 17 years for a drug, it's a little faster for devices. I think it's, what is it then, like 10 years or?
It's 8 to 10, yeah.
8 to 10. 8 to 10 years for a device. That's a lot of time to pay a lot of salaries to wait on hopefully selling something like that. Then 25% of all healthcare spending is waste. That's not good. It means we spend a lot of money on things that's not needed. So the next part I'm going to talk a little bit about payers, and this part gets interesting because you begin to look at like Who's going to pay for all this? So hospitals get about 50% of their revenue from managed care. Managed care means insured patients, okay? So insurance means they get paid slightly better. They get paid better than most forms of payment. But we have an aging population. And what happens when you get to retirement? Most people go into Medicare. Medicare doesn't pay as well as managed care. So you're shrinking your insured group and then you're paying Medicare, which is a lower rate. This is the chart over here looking at the number of people who are going to hit age 65. 20% are going to be age 65. When you add it to age over 85, it drops down. That's a pretty significant look. The problem is that this is a group also that has more chronic illnesses because they're older, which means it's going to be more expensive to take care of. So we have an aging population going into a worse payer mix. It's going to cost more to take care of them. I'm not trying to tell you these things so like you decide to change. Like, I'm leaving this, I'm going to sports. But I'm telling you this so you're aware of it. Because if you anticipate, you can solve. So hospital service contracts. This is always interesting. So, Ed's Blue Cross Blue Shield. I'm Lowe's or University of New Orleans at the state of Louisiana. And you're all hospitals. So you all go contract with Ed that, for a heart attack and this DRG, which I'll get to in a minute, we're going to pay Ed this much money to take care of that patient. And then Ed's like, okay. So he gets an average of all y'all and he says, and he negotiates with all of you. And he says, okay, you're going to pay this much money. And so it's like, it's going to cost me $15,000 to admit a heart attack patient. So I need to charge him $18,000. I'm going to make $3,000 in profit. So he's got to come over to me and be like, okay, I need you to pay 20, and then we negotiate down to 18. And then we lock that in for like 5 years. So that's the rate he's going to pay y'all for 5 years. Now he can renegotiate with me, but he's definitely going to do that with y'all. Lock it in, okay? So most contracts are 5 years or more, and they had a 2% growth rate. These rates are negotiated years and years in advance, and they don't take into account things like COVID, the Great Resignation, which I'll talk more about, or supply chain disruption. When these things happen, it increases your cost, but not his. So the hospital makes less. Does that make sense? Over here on the right, you have the COVID virus, and there you have an ambulance from Ukraine. Polynovo, Ed's company, is one of the ones that gave us products. So when we went over to Ukraine, we could take care of the patients there. And as we were leaving, we still had some of the product, and this group of British surgeons comes up, and they were so excited to provide care, and they're so good. And they're like, we got here, but we didn't bring any of the supplies that we needed. And so I went over and I was opening up a suitcase, and I came over and I was like, is this what you need? He goes, that's exactly what we use in the UK. And so it's just by luck that we had worked out and that we it's really hard to keep up with, and most times these rates have not kept up. And as a result, there's been mergers and acquisitions, there's been closures. I'm going to show you some impressive numbers here now. The other thing is that a lot of groups have had endowments, and they've depended on endowments to be able to keep up with it. The average healthcare endowment makes about 7.5% interest, and then they have a gift tax that comes out of that lowers it. So you don't actually get that 7.5%. You might walk away with 6 or 5%. But if the endowment does bad, you don't make money. Does that make sense? If you don't make money, then you can't pay your bills when you're depending on the endowment to pay for that program. This is an example of supply chain. What I want to show you over here is the top. This is pre-COVID, where demand and supply cross each other, you have fair market value. And you can tell that as supply goes down, demand goes up. As supply goes up, demand goes down. Does that make sense? This is what happened with COVID. We had no supply. And so prices went way up high. Way up high. And so doctors began using whatever they could use. And at one point, we were wearing trash bags taking care of people because we had no plastic napkins. Part of that was like what made the cost go so high. Shipping containers coming over went from $2,000 to $12,000 just to put something in a container and ship it over the Pacific. We depended on the federal government for something called the Strategic National Stockpile. That's made for surge, like having a hurricane, which people get hurt. It's not made for a pandemic. It's going to last a year. So supplies ran out. There's not enough for everybody. Now, big GPOs are building assurance strategies, and they're like, we're going to buy the mine that makes this metal that you need in your factory. You're going to then sell your product to us at a better rate because I'm going to make sure you have supplies. They're getting into it and owning the whole line. And if you watch commodities like plaster, polyester, latex, cotton, silicone, aluminum and titanium are two right now with what's going on in Eastern Europe. You'll see that these two are becoming more challenging as companies want to build and have things. And so it's not going to be easy. This is an example of like one of the doctors. This is the website I took a picture of yesterday, the one to show that it was still current. And these are masks off of Amazon for $6.99. They're the same box of masks for $45. And this has been hard on the hospitals and the executives. About 2/3 are looking for new jobs. There's been a lot of movement. I'm on my 6th CEO in 6 years. Now, 2 were interim, so let me give them credit. They were just looking for other people. But that's political capital you have to build every time. Someone has to come to New Orleans, adopt the culture of New Orleans, which is different, and then, want to stay. Revenues have not kept up with paces, and you look at it, margins are down, expenses are up. There are some hospital systems that if you don't have a 15% margin, the hospital gets sold. 15%. But if you look at national, margins are a lot more so than that, usually low single digits. This is the part that's scary to me, is that we have families that live in rural communities. There's 6,000 hospitals in the US. There's about 600 that are on the chopping block right now. And in Louisiana, we have about 52 of those 600, 19 at risk, 3 at immediate risk this year. And what happens when hospitals close, you lose service, you lose access. You lose access, mortality rates go up. So I bring all these things up to you because I'm not trying to depress you. I want you to be aware of why it's important to partner with doctors. Because you as an administrator or you as a leader in a hospital, you have stressors on the hospital that you're partnering with your doctor, you can help resolve. So we also see this as for our patients. And this is the part to me that's always really scary because nobody plans to go get burned. It just happens and it ruins their life. It's like, why did this have to happen? They're upset. So we look at, we have a lot of Americans that have bankruptcy. In fact, almost half of adults, when we look at it, medical debt is one of the major things that causes it. And in fact, in the last 5 years, many of us have gone into medical debt and don't plan to pay it off. 1 in 5 are never going to pay it off. So people are like, well, they got Medicare, it's okay. Well, Medicare is a 20% copay if you don't have one of the programs that goes with it, supplement. It doesn't matter if I take good care of you. If you get a $100,000 bill and you got a $20,000 bill from that $100,000 you got to pay off now, that's a big setback for someone on a fixed income. So, and it's more common in young adults than it is the older adults, mainly because they have a Medicare, they have something, but for young adults, this is particularly an age where people feel, I'm really healthy, it's not that important, I'll be okay until it's not. These are the kind of things that they give up. If you notice at the very top, one of the first things they cut down on basics like food and clothing, use up all their savings. This is not how we want young adults to be living. We don't want to be driving people to bankruptcy because they had a car accident, had a head injury or broke a leg, couldn't work, and then had medical bills that drove into bankruptcy. So it's important to me to find ways to not do that to patients. But this is an interesting chart here. These are the counties in the United States, and these are the rates of bankruptcy. And the darker it is, the worse it is, okay? Now, look at Louisiana, and let me show you this. This is where Medicaid expansion has happened. I don't care what your political alliance is. What I do care about is you understand that we are fortunate to have Medicaid expansion because compare us to Texas. And Texas is a wealthy state. They have a lot more bankruptcy than us when it comes to healthcare. And they have really good facilities. They have a lot more bankruptcy than us. So, I tell you all these things, you're like, well, I should not have a career in healthcare. And to back it up, like, I was a high school teacher. That's the high school I used to teach at. It's Madison Central. That was back in the early 90s. Yeah. I made $11,000 a year. Not enough to raise a family. That's bad. I know. It's Mississippi. So my family still lives there. My dad told me if I would join him and start the billboard business, I'd be retired at my age, and he was right. My parents went from making $12,000 a year for the last 20 years till they were retired, and I would have been retired with them. My brother was smarter. He started a car dealership, and he makes almost twice what I do each year. So I'm not saying that being a doctor is a good thing. What I am saying is that you choose healthcare for a reason. This is the top 10 or top 8 causes of death, and you're looking at age brackets at the top. Everything that's a colored box up here, I showed this earlier to the group, is a form of trauma. This is the US. This is Louisiana. This is the US. This is Louisiana. Red is homicide. Green is suicide. Blue is unintentional injury, like a motor vehicle accident. Your leading cause of death from age 1 to 44 is not cancer. Don't get me wrong. Like, I'm not saying don't run for the cure. I'm not saying don't give money to cancer. We're all going to die from something. We just shouldn't die young or unexpected. Leading cause of death from age 1 to 44 is trauma. And when you look at Louisiana, we don't do that great. The darker the state is, the worse the outcomes. Same thing for our kids. Our kids don't do that great. This is the #1 cause of death. What about the disease? The costs are higher. And the reason why the costs are higher is because if you're older and you have cancer and you die, you don't put a lot of cost in the system for a long time. If you're older and you have a heart attack and you die, you don't put cost in the system. If you're young and you get disabled from trauma, you put costs in the system for a long time. If you look at years of potential life lost, injury up there beats them all. And then you'd be like, well, Dr. Carter, you told me you have a lot of research funding. NIH is the biggest funder of research, and its budget is 0.02% to trauma. The burden of disease does not match the resources. And just as time we'll spend together tonight, more money will be spent on one form of cancer than all of trauma and all of burn combined. For the entire year. 1 hour of funding in cancer will be greater than everything we have in the entire year. We're so small in the NIH budget, we're not even a line in it. That's not okay. And part of it is that trauma is seen, and Ed heard me say this earlier, that it's inevitable. You had an accident, you made a mistake, it's your fault. But in reality, someone could have hit you while you were driving home. You could have been crossing the street, you could have had an accident. Your house could catch on fire from something totally unrelated, electrical or storm. Your neighbor's house could catch on fire, catch yours on fire. All these things can happen that you didn't make a mistake. And so I really try to move people away from the idea that trauma is is a bad disease or is for bad people. It's not that way. These are my 3 kids over on the left. That's River, the young one. When we first moved here, he was 1 year old and he was just learning to walk. My wife's from Pittsburgh. And she was unloading groceries real quick and he got out of the minivan and started walking in the concrete. And she came out and she's like, he's crying. And she picks him up, puts him in the van, and he's unconsolable, just can't. He's laying on the ground and she walks out there and he's like, what's wrong? So she drives him to a hospital. I'm not going to say the name of the hospital. And they tell her, ma'am, he probably broke his feet. You need to take him to an urgent care where he get x-rays. Urgent cares don't do pediatric x-rays of kids. And if you had a child that all of a sudden had a fracture like this, there's a lot of other things you need to be worried about. No one even looked at my son. I was still in North Carolina working 900 miles away because my partner, because there's only 2 burn surgeons at a big hospital that's 3 times the size of Washington. But with 2 of us, he was going to Europe. So I stayed to work for that month and a half to take care of the community for that half of the country, and that half of the state. My wife calls me and she takes pictures and he has blisters on his feet. What he had was 2nd-degree burns in the soles of his feet from walking on the hot concrete in a summer day in New Orleans. It happened that quick. So she asked me, where can I take him? I was like, there is nowhere to take him. You go home, you give him some Benadryl, you give him some Tylenol, you poke holes in the blisters, drain the fluid, and I was like, then we can put some lotion and some antibiotic ointment on it, and he'll be okay because it's the soles of the feet. Thank goodness it wasn't any other part of his body because he would have had to been shipped to Texas. My wife is a uber athlete, ultra marathon runner, all this kind of stuff. And I clearly keep up with her in the races. But she was running on a treadmill as we were driving back after interviewing here for a job. and fell in the hotel lobby, and I mean the hotel gym, calls me, and I have the 3 kids in the hotel room, they're still sleeping. She goes, I need you to reduce my wrist, I think it dislocated. And she comes up and she has a distal radius fracture. She's a broken bone right here in this part of your arm. And her wrist is a little crooked hanging off to the side. And I said, no, this is not a dislocation, this is a fracture. We need to go to an emergency department, go downstairs, ask the front desk lady, and she's like, I don't know where the hospital is here. So like, I'm Googling on my phone trying to find it. I find that there's a level 2 trauma center. It's 15 minutes away. So I drive us there, go into the ED, 3 kids in pajamas, just north of Atlanta. And they take her back, never come talk to me. An hour and a half goes by, never come talk to me. Another hour goes by, no one comes and talks to me. So I go up to the desk, I'm like, if you don't tell me what's going on with my wife, I'm going to call your CMO tomorrow when I get back to North Carolina and say, we're going to have words with whatever doctor's back there. And so the ER doctor comes out and he goes, don't worry, I just sedated your wife and reduced her wrist. And they got an x-ray afterwards. He's like, did you use C-arm? I said, no. He said, well, I happen to be a trauma surgeon, and standard of care is use a C-arm to ensure that you do not entrap a nerve and when you reduce it, and that you reduced it properly. He said, I do this all the time. It's fine, I promise you. Just tell her to elevate it and drive home. Do you have a hand surgeon that you know? I said, as a matter of fact, I do. This is a cell phone number right here, and I'm going to call him. So I called Chris and I said, Chris, it's like, I think I'm gonna need your help. He goes, okay, well, just let me know how she's doing. So she gets in the car, her hand is white, has no pulse in her arch, and she has no sensation or motor. What he's done is to entrap the radial artery and the median nerve in her wrist. We're in Atlanta, I live in North Carolina. I call Chris. Chris is like, I'll have an OR ready for you. Just drive straight here. We drive straight to North Carolina. I drive straight to the door. Nurse comes down from the OR. This is not the treatment that anybody gets in a hospital. They literally pick my wife up from there. They take her straight upstairs to the operating room. Like they stop by to put her in a hospital gown and holding. I take my 3 kids, drop them off with another trauma surgeon, come back to the hospital, sit there and wait. 2.5 hours later, he repairs the artery, removes the nerve from the entrapment, and puts a plate in to fix her fracture. Had he not done that, my wife would have lost her hand and her dominant side. So why healthcare? Because we need it. We need it. And let me give you an example. Like this is a case. Gross pictures. Let me give you caution. Gross pictures for a second. All right. So we had 42 burn injuries after Hurricane Ida. So you go buy gas, and when you go buy gas, you fill up the gas, static electricity, because you don't take the gas can out of the car because it's going to be heavy. So you don't put it on the ground like how the sign says. You just leave it in the back of the tailgate, or you leave it in the back of the Jeep or the SUV, which is wrong. Do not do that. Static electricity builds up. Boom, gas catches on fire. So your younger sister catches on flames. She suffers a 62% total body surface area burn. She's stabilized in the ER and then transferred to a burn center. Just pause for a second. 62% burn, younger sister. You're not going to the Taylor Swift concert now. You are not doing anything else that you want to do that was fun that evening. You're not going out to eat. You're not going to do your homework. You're not going to go to work that night. Your sister has a near lethal injury right now. So this is the average of the stays, 3.1, section 3.2 now, days per percent burn, 192 days. The average charges per day in a hospital in a burn center in the United States is $7,000. That means her bill would be $1.3 million before I had product, before the physician fees come in, before anything else. My cost, if I do as lean as I can be, one of the reasons why I work with Ed is because federal government and him have a contract for research, and we're trying to study, like, is there a way we can put some fake skin on people so that they can get out of the hospital and not have something that's painful that gets infected? And he's got something that looks really good for us to do that. And so my costs are at least $3,100, at least $3,100. That means my costs are going to be $595,000 if I take care of her for 192 days. All right. So fortunately, this is real life, real story. There's a spray skin that comes out, and this was the first patient in the Northern Hemisphere to get her face that was burned sprayed rather than like putting skin graft down. You can imagine if I had a gallon of paint, and like the normal thing is just for me to paint, so I'm going to go pour it on the ground over here. It's not very effective. But if I put it on the sprayer, that probably paint like that whole wall over there. Skin works the same way. When you spray it on, it heals differently. So we sprayed her zone, and her length of stay was not 192, it was 39 days. 39 days and she's home. No home health, not a nursing home, home. Cost savings, 434,000, charge savings, because costs and charges are different. Reimbursement, $184,000 in today's dollars. This is over 10 years ago, but in today's dollars, it's 184, which means that my costs are still 595,000. Did I do the right thing to take care of her? The hospital is going to lose $400,000. How many people can I do this and lose $400,000? Are you going to be the administrator who says it's the right thing to do? That's her picture on the day of injury. That's after we removed the burn on her face, 12 days later, or excuse me, 7 days later. That's after we sprayed the skin on her face. That's a year later, 5 years later. She doesn't look like she was burned. One of the reasons why I enjoy working with the companies is because they bring solutions for us. But if we don't tell them what our real problems are, then they bring the wrong solution. U.S. government just spent $247 million on a product that we didn't need, and the company just went bankrupt. That's $247 million of your dollars to develop something that we will never use now. It's right around. Yeah. So, but most doctors don't know the money. So most doctors do 4 years of undergrad, 4 years of medical school, asset average indebtedness. They do 3 years of residency if they go into family medicine. They do 5 to 7 if they go into most surgical specialties. Add on a couple of years of fellowship. That means 4 plus 4 plus 5 plus another 1, 2, or 3. We train a long time. I did 3 years of fellowship, for example. So 11 to 18 years, you work 60 to 80 hours per week. For our work hours, it knows this, like we were hitting 100, 120. I've done 120 for an entire year. And during my 2 years of fellowship, Randy knows I practically lived at the hospital. It's 36 on, 12 off. 36 on, 12 off. So 50K a year is the average salary in training. That means that you're one of the least paid people in the hospital. But your badge says doctors and you feel like it means something for you. But really, truly what you're there is to train and to learn. And then they get out and they do make a better salary. So I did something called a net present value calculation. How many people know what that is? Yeah. This takes money and it looks at the time value of it. And I also did it where I was like, well, let me just take this and let's not do the net present value yet. Let's just see like how much loan there is for these different specialties. What if I put this on a 3% interest rate? Because at the time I did this, it was a 3%, but we projected that interest rates would go to 6% in education, and they have. Now, what is the opportunity cost? Well, I don't even have to have opportunity cost on here. In fact, I can just add my interest and my principal together, and you can see the indebtedness. So if you train for a long time, you can see that you can come out and owe $1 million in interest and then school loan debt. So when people like my children ask me, should you become a surgeon? I tell them, hell no. Because you are heavily leveraged. If the payment system changes, Medicare goes bankrupt. And you don't have the positive cash flow to make up for this debt. You are upside down for life. So if there's not debt forgiveness or something else like this, it can really be terrible for the specialty. It also lets you look at like, there's some things that pay, you don't have a lot of risk. You can do it quickly and you can actually. So this is the net present value. If you don't know what this is a way of calculating money over time. So like if you win the lottery today, and my wife was one number off from winning the Powerball, and it was 110 million. So I put this up. So we won 35,000 instead of 110 million. Put us in a different tax bracket. We had to pay 25,000. We won 50,000. Put us in a different tax bracket. We had to pay 35,000 in taxes, and then the remaining 15,000 we split it. Half of it to charity, and the other half of it we took our families on vacation. But if you win the Powerball money, you don't get 110,000. I know it feels terrible. If you win the Powerball, you don't get 110,000. You get 71,900 in today's dollars. If you take it out over time, you get the 110 million. Which, if you took it all today, lump sum, you get 71 million. It's the time value of money. Meaning money today is worth more than money tomorrow, because money tomorrow you could have invested and used it. So we got some national early labor statistics. This is when I was with Dr. Kearns at Chapel Hill. We did a 5% discount rate, which is very modest. And then we looked at a lot of different specialties. And what we were looking at was like, well, which thing pays well? And what we realized is like social work was going to get a master's degree. That means a lot of education, and then their salary was less than the nurses. That was really concerning. Pharmacists get a doctorate. Some of them even do a clinical fellowship, and then their salary was not as much as a doctor. So they train for a long time, but don't make as much money. Look at 2-year RN. 2-year RN was kicking butt. 2-year RN was getting out, getting paid well, and didn't have all the risk that people had for going to school for a long time. So there are 2-year RNs right now, and they mostly want 4-year RNs, but you can get a 2-year and then have the hospital pay for you to become a 4-year that are over at the VA that are clearing 6 digits. And that's a really impressive salary for someone with a 4-year degree. But you look at some of the doctors, you're like, oh, that didn't pay as well. I'm glad I didn't become a pediatrician or a psychiatrist. And there's a reason why they didn't pay well, because they trained for a long time and they get out, they had a smaller salary. Now, Medicare is trying to make some adjustments now. They decreased surgeon salaries about 8% last year, and they put it all over to primary care. And they're going to try to do it again this year. That's not good for surgeons, but it just means that we will be less available. You will have less access. So we also did this for all the different specialties in surgery. We did something called an internal rate of return. The paper's called For Love Not Money. In fact, we're going to redo this, Randy, if you want to do it. I got a research Anastasia's working on this, so we pulled the data, and I published it with the College of Business at Wake Forest there. But we looked at different fields of surgery. And you've heard the adage: the more you learn, the more you earn. That is not true. Is that true? That is, to a limited degree, this is true. There's a point where you stop. You don't keep doing fellowships. After a 3rd fellowship, probably should have stopped it for a 2nd fellowship. I have a friend who trained for 17 years at medical school, Joe Molnar. Yeah. Well, what you see here is that there's some specialties that you actually got paid worse. You made less money over time because you went to that specialty. But the reality is, it's like if your hope is to take care of people who have cancer and you want to train in that, or if you want to live in a city and there's really competitive in that market, and the only way you can live in that market is to have specialty training. This is what happens. This has been published in orthopedics, pediatrics, and other specialties, and this remains true. You should pick a job because it's something that you love, not because of the money. If you chase the money, you never catch it. Hence the title, For Love Not Money. So I always ask people this. I always ask the doctors, the nurses, like, you ready to run a practice? You ready to run a group? Like, yeah, I've been doing this a long time. I'm good. Like, so just let me know where you got all this stuff in school. Where did you get sterilization, stocking, capital expenditures, par levels, pricing, conflicts, HR, equitable salaries? Where did you learn how to do these things? I can tell you, like, you don't find this in most schools. You might find policies, order sets, medical records, clinical documentation, because you deal with that. But you probably don't do billing, revenue cycle. Those are not things that most healthcare providers train in. Or they get this perspective of it when they need to know this. And so I tell them, it's like, you don't learn it all, and you don't have to. But it also asks, like, how good are doctors at business? And I'm saying this to you because you're going to work with us. So this study, they gave them an exam. This is one of the reasons I want you to come in, just to see this slide. They got half the questions right on the exam. This is a group of highly competitive people that are always going to get a perfect A, and now they only got half the questions right. During COVID, the California Medical Association, a big group of doctors, they surveyed it, and they got about almost 1,000 responses. 64% of the doctors in California had applied for financial assistance. 47% had to go into temporary housing. What does that tell you? They don't manage their money well. They're living beyond their means. They don't manage their money well. Is this someone you want managing your money? You manage my medications, but we manage my bank account. And then they survey doctors. And this survey has been true for nurses, and it changes depending on where it's at, but they're all low. And what's unfortunate is that less than 1 out of 10 doctors are fully engaged. Is that the type of person you want taking care of you? Someone who's like, I'm here. So this is the engagement pyramid. Like I showed you the learning pyramid earlier. The first thing you want to have is confidence. So I'll just take up my burn unit. My burn unit, we have a book reference handbook. You open it up, it's a bullet list. Doesn't matter if you're the nurse, you're the doctor, you're the student. We're all held to the same standard. That way, you know that when the patient has a fever, what the correct series of steps are to take care of the patient. So if I say, don't do that, do this, you can say, well, are you forgetting this? And, and sometimes you'll help, like, oh yeah, you're right, we should have done that. Other times like, well, I'm not doing that because of this. Those guidelines gives people confidence to know that what they're doing is the right thing. The last thing you want to do as a healthcare provider is hurt people. No, unless you're a psychopath, no one wants to go to work and hurt other people. Nobody goes to work and help you to hurt people. Integrity. You want to know that what you did it right. That means verification, accreditation, certification, recognition. Those are important programs to have because it tells you, hey, what you did was meaningful. It's also important to have it back from the patients. So like Randy knows, March 23rd, Saturday, we have our annual survivor reunion. We bring the pre-hospital providers who never get to see what happens to the patient, the paramedics, the nurses and the therapists, and the patients and their families all together. And they get to see each other. And as a patient, you're not wearing a hospital gown, your butt hanging out the back, and you can say, eye level, thank you for taking care of me. They can say back, thank you, and you can have that little closure right there, and you can move on with your life. And it's a social return on investment to the staff. And it's huge because it gives them purpose. It lets them know they did the right thing. It also makes them have pride. They have pride because they know what they did was good. They made a difference. Then that leads to passion. And on passion, I can call them up and say, hey, we have an event this weekend where the firefighters need some of us to show up and help them with a volleyball thing that they're doing to raise money, cancer. And they'll be, okay, how many do you need? They didn't ask how much you get paid. They do it because they care, they have passion. So like today, I needed one of my nurses' help. We had a bunch of people were trying to teach, like, I gave them all knives and gave them fruit. Like, okay, now go excise all the fruit. So you give a bunch of people knives and walk away. That's a dangerous thing. So I got my 2 PAs and I got some of our nurses like, do you mind teaching? And they went over there and they were able to do that. Now I told them that they were going to need to do it. I asked them politely and they were like, sure, no problem. But this is an important thing to understand, whether you're a doctor or nurse, whatever role you're in. Some people don't need to go past this. I'm going to put it in 3 groups. From a patient, you go taking care of like one disease or one person, and you're a new trainee to maybe take care of a whole unit, taking care of 3 or 4 patients or 7 patients, taking care of one disease to 5 or 10 different diseases. Everyone's looking at your clinical capability. They want to have clinical confidence. They want to know that you do the right thing. So you got to show, hey, I can do the right thing. But some people, they finish their training and they become really phenomenal doctors and they stop right there. And I said, you know what, man, I like just loading the boxes. I don't want to be the one driving the truck. I just want to load the boxes. And they enjoy it. They like just doing that. In fact, James Wong was just calling me over here. Guy does 33,000 RVUs. He loads the boxes. Oops. Other people want to, instead of doing something, they want to try to become something. So when you go from this next level, from a provider to a leader, now you don't want to worry about yourself. You worry about your whole team. You want the team does well. You're not just taking care of your patient from there, you're taking care of other people's patients. You're helping them. And you begin to look at things like, how do I prevent this disease, not just treat this one? How do they recover from it so that they don't get it again? And then you migrate up to like a regional or national leader. You're like, okay, how is this important for my state? I need to not worry just about myself or my team, my entire state. So Dr. Kearns and I have worked on some of those things, and I'll show you at the end. You want to worry about the entire cycle of care. And you worry about everyone's patients, not just yours, not just your hospitals, but you worry about other people's patients. And this is like the evolution from a leadership standpoint of your perspective. So this is how money is spent in healthcare right now. The big blue at the top is hospital. The orange at about 2 o'clock is physician services. The light blue down here is personal healthcare. The green is drugs. And this light blue over here is nursing facilities. This yellow is home health. The gray over here at 3 o'clock is clinical services. And so when you see these things, you begin to understand, okay, well, that's where the dollars are. Okay, I understand where money is spent. So one of the first things I did, I sat down with my CFO and I said, I need a financial health report. I want a report card. I've been in school a long time. Can you please do that? She goes, what do you mean? So I gave her a contract. I said, I want to be able to look at everything that you see up here. And I want to be transparent with you. I want to show you when I raise money and how hard I work and where I fail. I want to know where our denials come from when we don't get paid. I want you to tell me whether or not we're in the red or whether or not we're in the black. Because New Orleans had a burn center 30 years ago. It closed because it went in the red. And then for 30 years, there was no care. You had to go out of town. This is like a type of our contract, purpose, goal, operationalizing it, report request, income statements, but this is the most important line in here. To create awareness and investigate resolutions both administratively and clinically to reduce loss while optimizing patient care. That's a nice way of saying we want to be able to make money and take care of people in the best way possible, or at least not lose it. Okay. So for years, we have met 4 times a year. We go through the budget. And this is one of the reasons why I think it's important. This is from the AMA, and this is inflation adjusted, going through the years, seeing how payments have changed. And what you see is most things have done well. Hospitals do good. Like when I go home and turn the TV on, I see commercials for the hospital association. I don't see commercials for the physicians. Look where the physicians are. This is a real problem. But that's because we haven't been engaged. We've just trusted people to do it. But when you're not engaged, it's like if you don't balance your checkbook, you hope someone else does it. Then you don't have equity, you don't have advocacy, and you sure as heck don't have sustainability. So this is the cycle when it goes from a coding standpoint. And you didn't, I tricked you, we got into coding, you didn't even know it. So you have a patient encounter, it results in them documenting something. That results in a code. That code results in a charge. Hopefully that charge results in a collection. That collection results in solvency of the facility and the staff. That hopefully also results in provider in the practice solvency, which results in patient access. If I do a bad job clinically documenting and don't get my MCC and my DRG, and I'll explain that in a second, then all this goes down. The code goes down, the charge goes down, and I'll lose solvency. If I don't see patients because I'm lazy, this all goes down. Like I was a little late getting over here because we had a high voltage electrical injury. That guy needed someone to see him. So coding and productivity, these are some of the things that I hear from doctors. Ed's heard me say this before. My hospital isn't transparent with me. A lot of people say that. And how can we help if there's not transparency? That's the main reason why I come do this lecture. Every time Randy will ask me, I'll do it. I had a doctor say, I didn't know what an RVU was. I'm like, oh my God. I don't know who my coder is. You know who's responsible for our codes we submit? So if I have a coder and I pay them, I'm still responsible. If they submit the wrong code, I go to jail, not the coder. I have no idea how my productivity is measured. Oh, this is from a federal hospital. This is clearly something I'm going to have to learn. Yeah, no duh. So this is like 2 weeks of work on one slide. Okay. And what you see up here is the type of code in the far left-hand column, the name of it, because you see all these letters, you get this alphabet soup, you're like, I don't know what the heck he's talking about. Who owns the code? Like who's responsible for it? What's its purpose? And then just a few notes about it over here. So like ICD-10, that's the diagnosis that we give somebody. ICD-10 PCS is a procedure coding system. That's a procedure that's tied to that diagnosis. So if you have a burn injury and your diagnosis is cataract because it's the first one that came up and C came up before the burn because they put them in the wrong order. And I post the case, it gets denied because I posted I was going to do surgery for a burn for the diagnosis of the cataract. The two have to match each other, okay? CPT is how AMA makes over $100 million a year to license it out. Common procedural terminology. And Ed knows this, but doctors used to get paid in horrible ways. So Randy might do a below the knee amputation, get paid this much money. You might do it, get paid that much. You might do it. And then be in the same town, you get paid wildly different things. And you get notes, you couldn't figure out who did what procedure. So they came up with this idea that they're going to name everything so that they would be more consistent. And they'd make payments more consistent. And they said, well, when you go to the hospital, you tend to fall in these buckets. You're having heart problems, we have a bucket for heart problems. You have burns, we have a bucket for that. Those are called DRGs, diagnosis-related groups. And those determine how much money the hospital gets for that hospitalization at that time. Now, there's also another form called per diem, which is like, well, how much time you spend the money? I'm just going to pay this much money every time you go to the hospital. I might give you a big bucket of money, $70. And then there's things called evaluation and management, which is like when you go to the doctor and they see you in the clinic, they give you an E&M, an E&M charge. And then there's like outpatient. You have a ambulatory surgery center and it pays for the outpatient surgery. CPT is really important. It's determined by the AMA. It runs the world. RVU says how much that code is worth, relative value of work. So in other words, if Ed does a spine surgery, he's going to get paid this much money. If I do a burn surgery, I'm going to get paid this much. And they try to equate them. If you see 10 people in clinic while he's doing spine surgery, it should, how do those compare to each other? E&M is how we do clinic, and you can tell from these two sets of codes here. The last one tells you the level of service. So the higher the number, the higher the level of service, the higher the rate. It's really important to not mess up on these because you do a whole bunch of them. Like you might go to clinic, and I know one doctor is a hand doctor I work with. He would see 70 patients a day. That's 70 opportunities to mess up. Mine is like 10. Yeah. It's if you don't learn anything else, I would say these are the really important ones to learn. ICD-10, PCS, CPT, and HCPCS-2. HCPCS-2, the last one at the bottom, you have a HCPCS-2, correct? On BTM. What that does is, if you use something in the operating room, especially in the outpatient setting, it's supposed to be designed for, you can see all care settings, but mostly in the outpatient setting. And it's like you put a prosthetic in someone's arm, or you put a lens implant in their eye, or you use something that was expensive in a burn surgery case. It helps supplement the fee for that because it has a HCPCS code. And that means that they had to go and take a product there, get approval for it. Anything I'm leaving out on that? HCPCS.
What's that?
Anything I'm leaving out on HCPCS I should hear?
No, I mean, that's just.
Most of your PME and ambulance charges are HCPCS-2.
Yeah. So these are DRGs for burns right here. This is 2024 data, okay? So if you come in on the ventilator for 96 hours and I do a skin graft on you, this is how much money the hospital gets, not me. I don't do this, okay? But the hospital gets $184,000. So this year, I think I've had 4 people who've had that in the first 3 months. It's been a lot of sick people this year. This is the code we use most often. And if you see it says CC or MCC, that's complication comorbidity or major complication of comorbidity. And if you see 929 for 21,000, it says without that. So if you come in the hospital and you have congestive heart failure, that's a CC or an MCC. And I just don't bother to put it in the diagnosis. Give you some Lasix and discharge you. I get paid 21,000. If I put that problem list in there, because it's part of you, it's part of what I'm treating, I'm still doing the same thing, but I added the problem list and I comment on it. The payment just $48,000 for the hospital. When I first opened it, I didn't have PAs, but I told them I needed one. So they're like, well, if you get one, you got to show us that they're profitable. Now I have 2. You know what they do every Tuesday? They spend 2 hours going through every patient's notes and making sure that their problem lists are corrected. If I'm not going to teach residents this. Residents change every month. The PAs don't. And they make sure that if I'm not on call and another doctor's on call, that it's done. And with that, they pay their entire salary. This is if you don't operate. So you see why the surgery, it makes a big difference versus not doing surgery. So the hospitals want to have surgeries because it helps pay for a lot of the things that are expensive in hospitals. They don't want people to be sick. They want to be able to provide a service for them. This is for Medicaid in Louisiana. This is my hospital's public information. You can look it up. It's not a secret. But you can see that for a burn bed, they pay about $1,900 a day. So I already told you it cost me over $3,000 to pay for the nurse, pay for the food, pay for the drugs, pay for the equipment, pay for the oxygen, pay for all those things. They pay $1,900. What does that mean? I mean, do I not take care of Medicaid patients? For a long time, that happened in New Orleans. They'd have a bed for the insured patient, but not have a bed for the Medicaid patient. And so that was not here. Excuse me, that was not, it happened in Louisiana, not here in New Orleans, but happened in Louisiana. One of the reasons we opened a burn center is because people with Medicaid had burns and they needed to be treated. So what we do is offer everyone the same standard of care, regardless of their payer, but we work very, very hard to stay in the black because the costs are so high. So this is an example of 4 surgeries where, anonymized them. And those are the RVUs from surgeries. That's the equivalent of doing 77 gallbladders. And that was 4 days of operating, 4 full days. Or could have gone and done 77 gallbladders. This is a lot more fun. This is the average RVUs, and proceduralists like surgeons do make more RVUs than non-proceduralists like family medicine doctors. And you can see like what the medians are and how we look at all this information and see like how you do. And there are some doctors that, like you heard me say earlier, had a doctor phone call from a guy who did 33,000 routinely. All he does is operate day and night. Doesn't do anything else, which is really way too much. It's not healthy. We've been telling them that for 10 years now. There are other people that, when you do 2,000, you can't take them in the butt to do more. I bring it up because in burns, especially, my payer mix is not like cancer. I have a lot of Medicaid, I have a lot of Medicare, I have a lot of uninsured. I got to be able to take care of them all. So I don't have the best payer mix, but I got to be able to take good care of all of them. So what I have to do, I go through and I was like, okay, what's going to be the dollar per RVU? Because just like there's a hospital, there's a provider RVU, there's also a equivalence to this. Bless you. And what I look for is like, what is the payer rate from these things? So if you look at workers' comp up there, these are people who are injured at work. It's only 8% of the patients I take care of. But if you calculate it out, it's 18% of the revenue that we get. What I told the hospital and the state is, as long as I get both groups, I don't have someone cherry picking all the good payers and giving me all the bad ones. As long as I can take care of everybody, we'll be fine. But if you ever do it where we lose the good ones and all we have is the bad payers behind, I'll close and go somewhere else. There's no reason to stay. And that happens every day in America in hospitals. So I show it to you because it's important to partner with your doctor, because if you partner with your doctor and you say like, Dr. Carter, I need you to put in there that this person has heart failure because this is going to make a big difference to the hospital. And if you just send them a note and you never meet them, there's no personal contact, they don't know your name, don't expect a lot. You don't need to bring roses. You don't need to, be really like nice and kneel down. You just need to go tell them who you are and like why you think it's important. That can change a lot of those things. And this is not just true for the doctors, it's also true for the nurses. Nurses need to document things well so these things get captured. However, on the nursing side, a lot of it's avoiding penalties. So very quickly back in GPO, then we're done. All right. So the VAC is the Value Assessment Committee, and most hospitals have a committee that helps determine whether or not bringing a product in. Ed knows this. And it's multidisciplinary, it's a systematic process. The doctor will submit a request and say, I want to have this tool is what I need to take care of patients. You're like, really? This thing's $15,000 and why you want to do this? Well, I get out of the OR 15 minutes faster. Does it help the patient? Group purchasing organizations, totally different. This is like the Costco of hospitals. There's multiple ones, but these are like big groups that go together. So I'll sit on the panel for one. You know how much the revenue is for that company? $58 billion a year. It's huge. $58 billion a year. I go to their annual meeting and they have like NFL football players and all these speakers. I'm like, this is so cool because we don't have those kind of meetings in healthcare. We don't roll like that. But they also have like, hey, this is why it's important. This is what we do. We're going to help save you money. And it's interesting because they're basically a third party that facilitates contracts. They use the economy of scale to seek out the best values. And the way they do it is that they charge a fee to the buyers and they say, we're going to charge just like a credit card. So I want to show you our VAC form and then I'll wrap up and be done. So the VAC has 6 categories: risk, impact, education, clinic, cost, supply chain, clinical evidence. Okay. And every hospital is a little different, but in general, these things are pretty consistent. Negative, neutral, positive. Am I capturing this about right? And you see it's weighted with points. So risk impact, you bring a needle in and it makes it safer so you don't get hurt. Positive. Okay. You have less nurses injured. Education impact. You're going to put an implant in the eye. You don't have to train the whole hospital how to do it and all the clinics. Like if you change a wound back. Limited, positive. Clinical impact, reduces length of stay. Cost impact, replaces something else, shortens the length of stay. It does this like 70% of our cost is length of stay. Staff, it's not products. So if I can shorten the length of stay, gets money out of the hospital faster, saves us money. But then they have to be able to go home and thrive. Supply chain. If I have an agreement that I'm going to be 80% Ethicon and then Covidien comes in and they want to be 50%, it's not going to work. Clinical evidence. Do they have papers that are published in this? This is an example of that spray skin technology. So the National Burn Repository said the length of stay was 2.4 days per percent burn. That means 10% burn, 24 days in the hospital. Understand? This is for a cohort of patients unmatched here. All right. Our standard of care was 1.72. So we were better than the national average. Though we added a technology allowed us to spray the skin on, like you saw that girl's face, dropped it down to 1.19. So the question was it worth it? And the answer was, yeah, it was definitely worth it. It reduced our length of stay so much. And so these are other products that are out there. These are negative numbers for different products. I had seen these. I don't know if I've ever shown you this thing before. You can see, like, if the burns get bigger, 10%, 30% of the body, 40%, 50% of the body, the negative gets bigger and bigger and bigger. So if the insurer is not going to pay for it, you can take a $500,000 hit taking care of the patient. How many more patients do I have to take care of to take a $5,000 hit to take care of one? These are real questions you have to think about. And some of the technologies are not worth adopting because they do this to your bottom line and they don't benefit the patient. So I'm going to try to bring it all together. This is Mississippi River and those are barges. Y'all know this well. There's the airport over there, Lake Pontchartrain. And those barges are interesting because I don't know that you spend very much time thinking about them, but my son, we walk sometimes and we can see the river and we can see the barges, and he's always like, asking questions. And so that's a pusher, which is the boat that moves them. And each barge carries about 60 times what a truck does, a big semi truck. Carries a lot of stuff. They're heavy. And so they're big, they're over 200 feet. And I was trying to figure out, like, how does a barge stop? Like, if they see something that's in the river, how do they stop? Well, it's hard in the river because the river turns all the time. So I was like, well, what about a tanker? These things, like, it takes them on average, a barge 2 to 3 miles to stop. What about these big tankers? We have a huge port, natural gas, oil, grain, these huge ports. But these huge tankers, it takes them like 15 miles to stop. Now they have an emergency stop, they can do a little bit faster, but 15 miles. I was like, can they even see that far? And so I told you, like, I used to be a high school teacher. I guess we used to teach math and physics. And so, it made me think, like, how do they how do they look to see an obstacle? Well, it's important. So the Earth actually has a curvature to it, and that curvature is how far you can see. If we have anyone in here that's a flat Earth theorist, we can do the math. We can show you this is not going to work. But what's interesting is that your line of sight is equal to 1.22 times the square root of your elevation and height. Okay. I know you're in business and stuff, so you can do this math. Isn't that terrible? So, an average height of 6 foot, you can see about 3 miles. So if you're standing on that barge at the sea level, you can't see far enough to stop. You might be able to if you're on the barge, the tanker. You can't see far enough to stop. If you're at sea level, you have to be higher up. If you're like way up high in this beautiful church we have here in New Orleans that everybody knows about because it's on all of our postcards, you can see like 13, 14 miles. That's about the height of those tankers. So it's important that they're high up so that they can see far, far, far away and they can avoid obstacles. And I've told you all today about obstacles and then ways of avoiding them. So I'm telling you, it's important to think from a business standpoint that you plan. You have huge spreadsheets. I have a 54-inch monitor because I like big spreadsheets. And I do that. Everyone jokes to come in like this big, huge curve monitor. But your line of sight is very important when you lead. It's very important when it comes to business. Working with your physicians means having a better line of sight. I told you I would show you like the results at the end. The bottom 4 bars are the other burn centers, 2018, 19, 2020, 21, 2022. The top is our burn center here. And the red is big burns, greater than 20%, okay? And these are people who have like both their arms burned, the entire front of their chest, part of their head burned. These are big burns. And so nationally, other burn centers, only about 6.8% of their patients that come in have big burns. We do it up here in Louisiana. We have 16% of our patients have bigger burns. We take care of more injured patients. We look at inhalation injury. That increases mortality by about 17%. We're at 9.1, national average 6.8. We look at trauma. Like, if we're in a car accident and the car blew up on fire, jumped out of a building, fell off of a cherry picker, and they had electrical injury, those kind of things. National average is 9.3, we're at 23%. So we take care of people with bigger injuries that are more sick They have a higher mortality. This is their payer. This is Medicaid versus insured. So most burn centers, the insured is about 25%, Medicaid is 29%. We're 41 on Medicaid and we're at 19 on insured. So we take care of people who have bigger injuries, who have more stuff going on, more likely to die with less resources. But they get out of the hospital in less time. Now, if they get out of the hospital, they got to do good. I can't kill all these people. You know, it's not the way this works. So this is where they go. And what you see over here is the size of the burn, like 0 to 10, 10 to 20, 20 to 30. And the blue is where they go. The blue is going home, not to a nursing home, not to a rehab facility, not to a home health nursing, going home on their own. This is other burn centers. This is us. You take care of them so good. You start their therapy from the day one. You do surgery that helps them heal more quickly so they don't get weak and deconditioned. And they're able to go home. This is a team, not a person. This is really, truly a team. And this is what it's resulted in. This is before we opened. This is 9 months after we opened. This is 1 year after we opened. And that's the drop in mortality in our region, Louisiana. So to answer your question, yeah, it's worth it to take care of that girl. I did another net present value calculation, and I calculated how much it cost for me to hire my entire team. And I said, what if nobody had insurance and everyone was self-pay? Everyone was zero pay. So now I'm saying I'm not going to get any money from this. I'm just going to lose money on everyone I take care of. But they're not disabled. They're able to work and pay taxes to the community. That's it. And I said, okay, average age is going to be 32. That was the average age at the time. They're going to retire at age 65 because they're going to work and have a great life, and we're going to take good care of them. And I went all the way through. And by year 10, my net present value calculation was positive. And by year 33, when they were retiring, each year, because we had a whole cohort of patients that survived and lived each time, we were returning billions of dollars back to the community and people who were alive and working as opposed to disabled or dead. And that was with half the survivor rate and half the return to work rate that we currently have. So yeah, it's worth it to take care of young people. It's worth it to give them a chance. Only if you can stay in the black foot. So high value healthcare should be our goal. Transparency, man. If you can be transparent, accountable, that's it. Innovation doesn't always improve value. And then accurate documentation leads to optimal and equitable codes. These are some of my mentors up here. It's on white there at the top, and that's some of the burn team members over there. So I want to thank Ed for being around here. I dragged him over and said, I just want you to come see it, because this is the part of the presentation you never get to see, the business school side.
I sat in these seats. I actually tried to figure it out and almost made myself sick, by the way. 35 years ago. And had I known then what I know now, I might be sitting doing what he's doing. Now that I look at this thing, thank God I didn't, by the way. But I think, the only advice I have is you've got to find something you love. And going back to that hierarchy that Dr. Carter was talking about, I'm sorry, I think a little bit of time. It's got to be about passion. I've been very lucky over my 35 years of medical device to do a lot of things that I really love doing. And I spent a lot of time doing trauma and seeing patients on the other side. Sounds weird for a business person to say that, but it is what is the most rewarding. To know that your patient's not just alive, they're alive and thriving and are participating with their families, with their within society, as Dr. Carter said. I don't think he convinced anybody in this room to go to medical school. I'm sure he probably unconvinced some of you to go to medical school, probably calling some friends after this going, what are you doing? Get out. But I think what it should tell you is that there's an opportunity for us in business, right? In doing what we are. You don't have, this is rare that somebody knows the business like Dr. Carter knows the business. Most of them, you saw the survey you put up. They're incompetent with money. Right? They're the country club and a nice car, but boy, something goes sideways, they're in trouble. It's how can we participate at a higher level, whether it's at a hospital in their practice or doing what we do. I'm not going to help them with the economics, but I will be able to sit and I will be able to talk about how new technology and what you'll find a lot of times, not to take it too far of a side run. I've sold a lot of different things over the years. And usually what you find is when you bring a new technology to market and something that's revolutionary, there is that trade-off. How many things do you know that are revolutionary that are cheaper than what's out there already? Very, very little, if any. I sold a total disc. It was 3x the price of a fusion device. But I had to sit in front of the VAC, or I had to go sit in front of hospitals and tell them that the $10,000 surgery that they were going to do versus the $3,000 surgery they were going to do was going to be better for the patients, because it was better for the patients in the long run. But in the short run, they only care about, the hospital only cares about what happens in the hospital. They don't care about what happens afterwards. Some do, and those are the ones that we end up working with. I'm lucky enough now to have what I believe is a revolutionary product. It's a third of the price, half of the price of the competition that's out there. We could have easily priced it up with them. I'd probably be sitting a lot better than I am now, but I don't, it's not who we are, it's not what we are. And at this stage of my career, it allows me to do something that I am truly passionate about. And that's the only advice I'll give you is life's too short to solve the trauma things, right? You want to get a dose of reality. Look at how many people are affected by trauma. Do something you love to do something meaningful. If you chase the dollar, you're gonna chase the dollar your whole career. I can say that I did not chase the dollar, and my wife will tell you, I've taken 3 pay cuts over the years of 50% or more to go do something I wanted to do. Try that with raising 3 kids and going home and telling the wife you just took a pay cut. So, but it was worth it. Every time I did it, there was a version of me that got to take a step back, because I was taking a step forward. I was doing something different with my career that would make me more eligible to be what I am today. And it wasn't just I want to be a salesperson. I just want to be this. I wanted to round myself out. And so to go home and say, I'm quitting my sales job and I'm going in-house to do X, Y, and Z. Oh, and by the way, we took a 2/3 pay cut. And we're moving to California, which was more expensive. Start adding those things up. And then what my plan was, what's next? My goal was never to be what I am today. My goal was just to be better and have options. I'm trying to raise 3 kids. I lose this job, my resume looks like this. I can go anywhere I want to go. And that's been very fortunate for me to be able to do those things. So again, life's too short not to go to work and hate what we do every day. I've got 2 kids that are graduating this year from college, one from Ole Miss and one from Chapman. And I try to tell them the same thing, but I'm letting them go do what they want to do, and they'll figure it out. You'll figure it out. But there's a lot of good people, and yeah, there's nothing but great things about you. Rely on them, talk to them, look at your options, have fun. That's the best part. Enjoy this. It didn't get much easier than this. I didn't realize it at the time either, but enjoy this.
All right, questions? Mr. Wallace, thank you.
I have a question. It was okay, so when you're talking about like hospital service contract and nobody accounted for like inflation, or was it like
They did. They gave a 2% inflation rate because that's what it had been for a long time. Nobody had a pandemic in this lifetime.
Okay, so nobody thought that, hey, it's been like 1,500 years. Maybe something crazy is gonna happen. That's gonna should go down like 5 years ago.
You don't plan for the outliers. You stay within. You have 2 standard deviations of the norm.
But you don't have
You need an emergency fund.
That's not. I mean.
So it's true. And so to me, that's what endowments are really good for. And that Randy knows, for the American Burn Association, we had no endowment. Don't have this. So when COVID hit, we almost went bankrupt because we weren't having meetings and nobody was paying money for anything. And then I went through and reviewed 400 nonprofit professional societies in the United States, and all the good ones had endowments. I told them, we need to start saving our money and having an emergency fund. I'm happy to say in 3 years, we've saved $3 million, gone from the red to being in the black, and we have $3 million in savings. And we probably don't need to do any more than that. Now we're getting greedy, but that's enough that if something bad happened, we'd be able to stay open. We wouldn't have to close shop. Yeah, it's, but for the contracts, no, they don't plan for the outliers.
I have another question. So the burn center is with the trauma center. Okay, so like when people have like really bad, like they're on a school really bad, really bad. They're like scraped up and stuff, you gotta see those two.
Yeah, it's so a lot of times we'll see which is worse. If they have bad trauma, they'll go there, like if they're bleeding, head injury, things like that, they'll go
Right.
there. And then, but if the burn is a more serious injury, they'll take them downstairs.
I'm curious.
But not all burn centers are trauma centers. Not all trauma centers are burn centers.
Okay,
But most burn surgeons are trauma surgeons.
Yeah, yeah.
It wasn't scary that like y'all opened in 2017, that's like a year and a half before COVID. Cause COVID technically was around late 2018, 2019. That wasn't scary for you guys?
No. Because all the things we do for inhalation injury, all the stuff they did for COVID. We
We
were
just
ready.
lost a lot of our capacity to care for burn patients because
Yeah,
they were all in
yeah.
burn days.
Because we're all critical care trained. We could all take care of COVID and take care of burns. We were your Swiss Army knife.
Y'all was just not getting two birds at a time. The patient with the face burn, was that your patient?
Mhm.
And you like reconstructed her face, like you took this.
It wasn't that fancy. All we did was use a water knife to cut the burn off, that just sprays water. It'll tell you this, you would think that this is like, oh, super high tech, fancy goggles, laser shooting out stuff. It's not like that. It's like, looks like a fancy toothbrush. It shoots water off, but it cuts the dead tissue off of the thickness of a credit card or less. I can turn it up and down to make it cut from a big area to a small little tiny area. These are like a baby's eyelids. So we take a small piece of the skin, we pull it from their body, or we use like a little device that shaves it off, thinner than $1 bill. We put it in another machine in the operating room that heats it up, and then the cells separate the stem cells from the skin. Can't grow like another Jeff Carter from it, just grow their skin from it. They separate and we're able to scrape them away, all within about 30 minutes. Take those cells, put them in a syringe and spray them on. Or something like what Ed has, where it's like it looks like something you pack dishes with if you're moving. And it's crazy because like if I took 50% of your skin off your body, you die. I could take a kidney out, you can be fine because you got two. You can lose a lung, you'll be all right. You can have a heart attack, your heart not be working that good, still be okay. You can have a stroke, still be eating, talking, walking around. But you can't have 50% of your skin. You can't have 10% of your skin, you die. So what's interesting with the skin part, I'm trying to remember where I was going for this. You're asking about heck, I forgot where I got on the stroke thing and I forgot. Sorry. Maybe I'm having a stroke.
Spray on the skin.
Oh, the spray on. So yeah, so what his does, normally if you have like a big wound like this, the body just has this huge inflammatory response and it's just like struggling to heal. It's just like if you had like a landslide in your backyard and you're missing this part of your yard. It's like, everything just slides down and it's a horrible wound that just forms this really thick, gnarly scar. So he's got something, and what I can do, I can put it on the body, and it thinks it's like, oh, it's okay, I got skin. It's all right, not that bad. I'll grow some little blood vessels into it. And then when you're ready to put a skin graft on me, you can just peel my top layer off, just like opening up a Coke or something. Just peel pop the top, peel it off, and then you put the skin graft on. Is it painful? Put it down and put their sleep with that.
Like, I was in wound care, so people need to know like what it's made of, like the skin.
Well, this is a polyurethane. It's a plastic. And that's what's cool. That normally, if it's a biologic, we got stuff from sharks and goats and sheep and all kinds of things and pigs, and those are fine, but they're biologic. We have cadavers. They're all biologic. Biologic means I can give you an infection with it, or I have to go kill a bunch of pigs with it. And like that's, if you have a big disaster, which is one of the things we prepare for, we talk about a lot. Is there's not a lot of pregnant cows you can go get their skin from the fetus. That's where they get one of the products from, for example. Taiwan, they had a big burn over there, big fire. They ran out of cadaver skin.
So with burns, one of the biggest issues that they saw in the military, is that if it wasn't like for the night, if it wasn't the explosion that killed you, it was typically the infection from the burn. So granted, this particular product, of course, would increase the healing rate and therefore reduce exposure to infection. But how initially in the beginning, what does it look like with infection? What's the body's response to it? Do we see a decrease in infection or about the same?
So as we cover up the skin and we put something on top of it that acts like we call it like a plastic skin. What you see is that it's still is an open wound. It's still at risk for infection, but we see it's less than doing alternatives, which is like putting something that's biologic, but you get infected on it, leaving the wound open, or keep putting antibiotics on it until you get something that's resistant to those antibiotics, and then it gets infected. So it's nice to put something on that kind of tricks the body, because what it's really doing is like instead of thinking it's a big wound, it's like, oh, so there's a bunch of really tiny small wounds. So I trick my kids with this, like whenever they have to clean the room, I'm like, you mind just picking up your Legos over here? Oh, you did a great job with that. You mind picking up your shoes over there? If I say clean the room, forget it.
Have y'all had that like device when I was still like the military or anything like that?
Yeah, all these are used in the military. In fact, the military funds most of it.
Yeah.
That's why you saw the Department of Defense funding them. I said, they're actually some of the best ones.
When I was at launch school, they had something similar like that at that hospital. Because they treat, overseas and.
Yeah. They actually helped fund some of the original science behind it.
This may actually be a better question for you instead of you. What's the flammability like of the actual plastic?
What's the what?
The flammability of the actual plastic?
It's not, I would call, it's not flammable necessarily. I mean, obviously, if you get it hot, it's gonna get, I guess it's gonna melt, right?
Right.
But you're hoping these people can do one burn, that they're gonna keep it away from anything else that's gonna get that hot. We've not had that issue, but it is not something that would be able to catch on fire.
The reason I ask is because I used to work for a laboratory when we were trying to develop a flame and heat resistant face paint for the military. Because what would happen in an explosion is the face paint was actually going to flames.
Right.
Yeah.
So, but that's the reason why I was just curious if it's something that could potentially be expanded on research, but.
No, that's funny. Dr. Carr was talking about a story today about somebody putting a cream on that actually was flammable. What was it? It was the
For psoriasis.
yeah, psoriasis medicine that's flammable, and somebody lit something, and so we're all very, obviously with the FDA, we're all very cognizant of further injuring somebody who's already been injured. That's something we all kind of pay a lot of attention to, as you know. So it's a primary concern.
Any other questions?
It's rare that you get a CEO from a company. It's
not- you just
president.
Once fun.
I will tell you, like, if you fill those shoes over there, you've done very well in your careers. You just happen to be in town, so I was like, Randy, do you mind if I break the opportunity?
I love it.
One question, some of us are curious, how did you come up with this, like,
So I didn't, which is why the device exists. There's no way I can come up with it. It was actually, so I don't know if any, so back years ago with the Valley bombings, you remember the terrorist attack in Valley? So what happened was there was a lot of Australians that were in Valley for vacations. A lot of those patients came back from Bali to Australia to be treated. And what the doctor there found was that there was a lot of infections because they were using a biologic product. And these patients came back infected, and again, worse than not just infected, but like hard to get better. So what that doctor did was, I need to find something that can fill this void. And our product was actually developed by the same place that developed Bluetooth technology out of Australia. It's a publicly funded group. They had this technology. He tapped into them, and it was literally a doctor found a need, had a need that this technology fell into. So it's called BTM, and again, it's a medical grade polyurethane, but with the way how it's mixed and then sealing membrane on top. The sealing membrane controls the heat and the moisture, which, like Dr. Carter said, if you lose all your skin, those are two things that are going to, it's one of the things, one of the things that will absolutely kill you is the heat and the moisture, the loss that you'll have from that. But what he did was, this product was developed for a clinical need. This was not a product that was thought of from a commercial standpoint. Like, let's go do this and turn this into this big commercial, you know, a bunch of guys sitting around trying to figure out how to make money. That's not how this came about. Do we make money? The answer is yes, right? We're a commercial organization, but that's why our costs and why we do our pricing the way we do our pricing. But I will also tell you that we're not a company that's highly driven off of delivering a lot of profit to our shareholders. And our shareholders seem to be fine with that right now. And case in point is, we're in 39 countries. How many companies do you think medical devices make profit in? It's a handful. Every place else, we mainly lose money. You know, it's US, Australia, Japan, and there's a few others. Every place else, you end up pretty much breaking even or losing money. We just went into India. So some of our shareholders are like, well, why did you go into India? We could just do all our business in the US and we'd be very profitable and our stock price would be high, but that's not who we are. We put the money back in. And so why did we go to India? Because there's a need. There's 7 million burns a year in India. 7 million. Out of those, hundreds of thousands die every year. Hundreds of thousands are horribly disfigured. Not only just disfigured, I mean horribly disfigured. I was just there. Somebody who's got a 50% TBSA, which means half their body, they can't operate on them, or they don't operate on them. They just end up dying because they don't have skin substitutes, meaning not just our product, but then you have to have enough skin to put down after you put our product on, and they don't. So they don't have no way of treating some of these patients that have something that Dr. Carter might do. You saw his numbers on the larger TBSA. We do them here. We say people who have 95, I have 95% TBSA. 95% of your body's burned, and they find a way to save those. There's patients in India who have 50%. But the other part of that is that there's 7 million burns. There's an absolute need for a product like ours because we're synthetic and not a biologic that needs to be stored at minus 80 degrees Celsius. So there's no special handling, basically, is what I'm saying. It's an environment that we can survive in. Out of those, 4 out of every 5 of the burns is either a woman or a child. We have an obligation as an organization to go. This is why the product was developed. And so that's what we're doing, is we're going into countries like India and others because there's a need for it. And again, we still have to be profitable, and what we do here in the US does fund. I'm not gonna, does add extra weight to my team here in the US to perform so that we can do those type of things. And it's like Dr. Carter's not doing this. You saw the salaries, you saw the money. There's other reasons to do things that we do, and to see it in action while I'm over there. And the hardest part was literally walking through the hospital and seeing somebody and talking to the doctor and go, well, what will you do with that person? Like, there's nothing you can do. And it's like, and stick on a plane, be here, and the patient will be fine. That it crushes it. And just like Dr. Carter was in Ukraine, same thing. Not able to treat things that we see here very regularly. So it's about social responsibility too. Yeah, I'm not going to sit here and say we're not a commercial organization. We're public. We have to report. We have to do those things. But we could certainly do things that would be much, much more profitable and probably make a lot of some of our shareholders. Most of our shareholders know exactly who we are and what we are, and still invest in us because of how we do it. And that's the part that I'm most proud of. And I'll be honest with you, I have nothing to do with that. I've been here for 5 years. The product's been around for 10. So I don't deserve any of that. It just met with my internal, what I wanted to do. And so that's why I'm here.
2 reasons why the numbers are what they are in India. In 2017, when I was there, about 63% of all meals consumed in India are prepared over an open flame. So you've got a source. Then the second piece is, hey, you get 7 million. Well, at 1.4 billion people, they're about 4.5 times the size of the United States in population. It's a huge country population-wise. 60% of the meals are cooked over an open flame. It's really easy to get to those large numbers that way.
Yeah, and you've also got the industry with not a lot of controls, right? We've got a lot of agencies here that we've all paid for in our taxes that's supposed to control a lot of this. And the other part of it is that doesn't even take into account a lot of the trauma. And all you have to do is take one drive around India and you just wonder how there's not more trauma. Because I'll tell you what, it's a harrowing experience. Anything you've seen on TV, you know, I come from the airport, you'll know this, I was in Delhi and I'm in the airport talking to my son. And he's like, so what's the traffic like? I go, it's 3 lanes and 3 lanes. Problem was, there was 7 lanes of cars in 3 lanes and nobody uses turn signals and nobody looks. They just go.
There's
I mean, every time I'm looking down, there's cars this far away from you. And there's cars coming at you the other way, or motorcycles, because the other side's too jammed up, so they're coming back. I just like, there's no way I'm ever driving here. I don't rent a car, and I will never drive here because it is
Always have
all hurt somebody. And road rage doesn't exist there. I would have to.
other questions.
Sorry, you have a big like factory, so it's like chemical burns too.
So, yeah, we can do any burn, so any burn, any trauma, I don't know if you've heard of diseases like necrotizing vasculitis. We do that, we do, you know, there's, you said you were in wounds, so DFU, you've heard of DFUs and VOUs, you know, venous leg ulcers and diabetic foot ulcers, we can treat. So anytime there is a devoid of the dermis,
Yeah.
there's a chance to clean it up and then put a product down, whether it's us or somebody else, there's a chance to serve that patient with a dermal substitute. Which is what we call skin substitutes or dermal substitutes.
Anybody want one last question? Then thank you. Thank you, Jeff. Tell you what, if y'all want to take about a 10-minute break, if you're in class for 6010, we've got a couple of things we need to go over for this section this week, but we'll wrap up quickly. If you're not in the class, then you're clear to go, but I appreciate you coming. Actually, if you'll send me an email, I'll be sure you get extra credit. Okay. Thanks. So nice to meet you. Very good.
Thank you. Great. Thank you. Thank you.
Ship any boys over to the girlfriend.
Yeah. Yeah, a little bit there. Walter Reed with all the army folks coming there.
Great stuff. It's out on the wire when it was first coming around. Hear about it. You never got to play with music like that.
He's a big, you know, the success, for all the success he had, and work with the FDA to get it through it.
Sure.
Trying to get the BARDA done and we get the BARDA done and it's going.
Good stuff. Hopefully we never have to use it.
No, I hope you never do so. I hope you never do it. Thank you. Nice meeting you both.
Right. What years were you at law school? What years were you at law school?
I was in lawn chair hold on 2017 to 2019.
You're after me. You're young.
Oh, that's a puppy.
I was there 2012 to 2009 to 2012.
Oh,
That
really?
was the last meeting, the expedition and medical was there.
Wow.
We handed over to Charlotte Company in August of 2000.
Wow. I was medical logistics. I was on.
You took over everything you had. So,
Yeah.
We had it for 14 years. And then handed it back to you guys.
Mhm.
I was in the women. The deployed warrior medical management center.
Yeah. Wow.
Saw all that. So
I know, like when, I mean, well, I was just on